So our next talk is by Dr. Eric Wallace, Professor of Medicine and Director of Rare Genetic Kidney Disease and Chief Medical Information and Digital Health Officer at the University of Alabama at Birmingham. Thank you very much, Dr. Wallace. I would say perhaps the preeminent expert in also Fabry's disease, clinical management and diagnosis of Fabry's disease, perhaps the largest single patient cohort, at least here in the US, of patients with Fabry disease. I know when I was a fellow, I learned a lot from your work and uh, contributions. So looking forward to your talk. Thank you.
Thank you. Yeah, well, first of all, excited to see 108 people on a Saturday talking about genetic kidney disease. So thank you for your attention and being here. It's something that's really exciting to me. My start was with Fabry disease. I was a new attending when Dr. Warnock took me under his wing and taught me about Fabry disease. But when it started, it was actually relatively boring because what would happen is you could test for one gene. Fabry disease was easy because you had sponsored testing, but any other genetic disease, a single gene cost about $3,000. So you go to your patient and say, I think you have this gene and we need to do testing and it's $3,000. And you're like, none of my patients could afford that. So we'd say, well, we'll just treat you like you have the disease. The other thing was that there were genetic diseases like Bartter syndrome, for example, that have 5 potential genetic mutations. And by the time you got to 3 genes, you might as well have done whole genome sequencing, which was $10,000. And it just nobody got genetic testing. And really, the revolution has happened with gene panels, which is really in the last 3 to 4 years because the cost of genetic testing has gone down dramatically. The interpretations have been much, much easier. And so what we did, we expanded our Fabry disease clinic to be all rare genetic kidney diseases. And so that's where this talk originates from. So very excited to be talking to you about it. All right. So these are my, although there's Sanofi on the slides, these are my slides. There's been no input from this. These are my disclosures. Pretty much I work with anybody who does work with Fabry disease because we have one of the largest cohorts, and also some work with Natera, which is the gene panel testing company, only because really gene panels have truly changed the way we view and are able to get genetic testing. All right. So why test? So I had to talk about this, but just, put yourself in clinic and say, why am I going to test? So, first of all, let's get rid of some of the fallacies. Some of the fallacies is, oh, if it was genetic, it would have been caught by the pediatric nephrologist, right? I don't need to know it because I'm an adult nephrologist. Peds would have gotten it. That is 100% not true when it comes to genetic kidney disease. So you have to say, if you're going to use anything new, and this is not just genetic testing, in your life, there will be many, many new things, and you'll have to convince yourself, why am I going to do this and spend time for it? Well, so this is what we're going to do. I'm going to give you some real life examples of patients that I've encountered and the interventions and how it has changed management. So first of all, you definitely need to test for conditions amenable to treatment. Last thing you want to do is miss a disease that you could have treated and changed the outcome. Many of my Fabry patients found out they had Fabry because their 40-year-old father died. And that's not a good way to get diagnosed with a disease. So conditions amenable to non-specific renoprotective therapies, this is like Alports, avoidance of prolonged immunosuppressive. So we'll talk about some cases of that. Conditions at risk for recurrence for transplantations, and informing, do you need multiple organs transplanted instead of one? Extrarenal manifestations is some of the things that I do most, which is I identify a genetic disease and I say, wait a minute, this isn't just affecting your kidney. I need to screen brain, hearing, neuropathy, aortas. I mean, you name it. These diseases usually do not just affect the kidney. And if we don't know about the genetic disease, we're missing an opportunity to diagnose the whole patient. So now, before there was no real guidelines, but luckily now we have guidelines for genetic testings. This came out of KDIGO. And what are some of the salient features? So I want you picture yourself in clinic and say, how many patients have you seen with a positive family history of kidney disease? And by positive family history, one family member with kidney disease. I can tell you that very frequently, I was up until about 2 weeks ago as director of home dialysis for my institution, and I always asked patients about do you have any family members on dialysis? And I very frequently have patients that said, I have 3, 4, 5 family members on dialysis. Nobody had done genetic testing. We do it, and then we reveal why. That is important. Hopefully, we can go a little bit more upstream. Syndromic or multisystemic features, these are what I call the CKD plus syndrome. So I have chronic kidney disease plus neuropathy without diabetes, chronic kidney disease plus left ventricular hypertrophy, irritable bowel syndrome, et cetera. You say, yes, my patient has a whole lot of complaints, but could all of these be one diagnosis? So they have CKD plus, and then you say, well, maybe let's do some genetic testing. Possibility of identifying a condition amenable to treatment. The individual is an at-risk member of a patient with known monogenetic kidney disease. These are all good reasons, but think about your clinic and say, as you go through this, you say, how many people have I missed? All right. Now, interesting enough, it's not just KDIGO. So it used to be KDIGO was the first one. Now we have the NKF has genetic testing guidelines. You have New England Journal. And you know how many times nephrology gets into the New England Journal. It is not frequent. I know for home dialysis, we have 3 papers in the New England Journal. So when things start coming to attention in the New England Journal, we have to start saying, look, the standard of care is likely starting to change, right? So this is all of these are new genetic guidelines, which we just had a fantastic talk on. So RenaCare was one of the first large-scale, multi-site proactive study of comprehensive genetic testing. So in this study, they took 1,600 patients with kidney disease, and in order to get into the study, you just had to say, as a nephrologist, could this be genetic? And you send panel. That's it, right? So it is a selected for population of patients. Nephrologists who are interested in genetics say, could this be genetic? I'm going to send a panel. Now, what you'll see is that there were only 31% that were non-white, 51% were female, but one important thing is that the average age of this population was 55. This is definitely not a pediatric cohort, right? 31 centers. All right. Now, these were the results. So if I, as a nephrologist, think this might have a shot that this is genetic, 1 in 5 came back positive. So here's the problem, and this should say why I'm so excited about this type of testing, which is that the incidence of Fabry disease is 1 in 40,000. So if I'm a nephrologist and I send 200 Fabry tests, right, and 200 come back negative, guess what? I'm done, right? There is no positive reinforcement. There is no use, right? So we have a psychology too. So one of the things that will drive your genetic testing is when 1 in 5 of these tests come back positive, and you truly start seeing the effect of the test, which takes extra time, right? You have to fill out the test. You got to counsel on genetics. But as these change your patients' lives, you will start to order more of these tests. And that is how panel testing or whole exome is much better than thinking about the one disease. It was really a losing battle to try and get people to think about Fabry disease. And one of the reasons is there's 20,000 genes. Those 20,000 genes, based on alternative splicing, make about 150,000 proteins. Every protein can have a gain of function, loss of function. And at the end of the day, we humans cannot keep this straight. So operationally, we have to operationalize something that says, could this be genetic? If yes, send test, right? And then it's all collated for me and I get the results back. All right. Now, of those, it wouldn't surprise you to say that the most common genes that were affected or detected were PKD, APOL1, right? And then PKD2s, right? This is how common those diseases are. However, Alports were number 3, 4, and 5, right? Or sorry, 4, 5, and 6. So 4A4, 4A3, and 4A5. So already you start thinking, well, how many of these am I missing, given that 1 in 5 was positive, and now Alports ended up being 4, 5, and 6, which had historically been thought to be much more rare than this would have it be, right? So the other interesting thing is that when I think about sending one gene, the issue is, well, what if somebody has 2 genes? How often does that happen where I get 2 genes that modify the phenotype? And it turns out, if you look at this, there were 6.2%, 6% of all of these tests that had 2 genes affected. So now all of a sudden, I got to say, well, wait a minute, if I see a single gene, even if it's positive, I might be missing a second gene involved. All right. So Diagnostic utility. So did it change what I'm going to do, right? Or did it change my mind? Because, if I have somebody who has PKD and I send a genetic test and it has PKD, I say, well, did it change anything, right? So 34% of the time, the genetic diagnosis was consistent with the clinical diagnosis. And that actually makes sense if you think about PKD specifically. PKD was the most common. I do an ultrasound of the kidneys. I have cysts on both kidneys. I think it's PKD drives this result, right? But if you look at 34%, that means that 66% of the time, that was not the case, that it either changed my diagnosis or modified my diagnosis, which modified my treatment in some way. That is a huge percentage of diagnostic utility, right? Now, 33% of those positive cases reported a change in treatment with genetic testing. So I send the test, 1 in 5 come back positive. Of those, 1 in 3, I change what I'm going to do. That is not a small number when we talk about the numbers of patients you're going to see over the course of your lifetime. So let's just talk about some of these examples. So conditions amenable to treatment. So you have a 50-year-old male who presents for a second opinion for CKD4, right? So he has a past medical history of an arrhythmia and an ablation and a pacemaker, right? So he had a kidney biopsy before from his previous nephrology, and unfortunately the biopsy was unsuccessful and only got medulla, so we didn't have information. So he asked his nephrologist says, I think you need another biopsy, to which the patient says, no, thank you, I am not doing another biopsy. All right. Physical exam, his blood pressure is 110/60. He has no rash, no family members on dialysis. And his echo actually was normal, had no left ventricular hypertrophy. So, just CKD4. So she offered him genetic testing. So genetic testing was performed, and it turns out he had Fabry disease and Alport's. Now, this was an African-American male, and I can tell you we are missing this left and right in underrepresented populations because I have many African-Americans with Fabry disease. None of them have the classic angiokeratomas, right? So it tells you that as we get genetic testings, we are continuing to inform ourselves about the diseases. All right, so now genetic testing alone, I didn't, you got to confirm the diagnosis. So we did lyso-Gl3 level, that was elevated. We did enzyme activity level, it was 0. So we say this is Fabry disease. Now what? What are you going to do with these results? Well, it turns out I have a whole lot to do, right? There's a lot of other things I need to do because this patient now has Fabry. First, I need to check his heart. I need to do a cardiac MRI because an echo may not be sufficient to identify left ventricular posterior wall abnormalities. I need to monitor for them for arrhythmias yearly. I also need to make sure I understand his aortic root. So 10% of patients with Fabry disease can have aortic roots, and I've had, unfortunately, patients present with aortic root dissection who are Fabry patients. So neurologic, so patients can have white matter disease. So I need to scan the brain because patients have been misdiagnosed with multiple sclerosis because they did not put these two things together. I need to treat their lipids because they're at higher risk of stroke. So our Fabry patients get treated to an LDL less than 100. Patient had irritable bowel syndrome, so I need to monitor them for that and treat it. Now, interestingly enough, this patient had already identified a family member to be his donor. Well, guess what? We had to screen them and they had the gene. So that's a problem. So one of the most heartwarming things that I do in my clinic is whenever you give a patient a genetic diagnosis, the first thing they ask about is, what about my kids? So this patient ended up having kids. We had to screen the children to prevent these manifestations in the future. So, it just keeps on, you peel the onion back and you have more and more things to do because you did the testing, right? So, and then finally, there's existing therapies, clinical trials, et cetera, that we can do. So let's just talk about the power of widespread genetic testing or easy genetic testing. So this is a study we presented at ASN in November. So we looked at the Renasight panel, 67,000 tests sent. Of those, if you look at the standard population, the incidence of Fabry disease is about 1 in 40,000. But if a nephrologist says, this could be genetic, out of those 67,000, 111 patients were positive for Fabry disease. That is a prevalence of 1 in 600. So if I get this test 1 in 600, and I promise you guys over the course of your life, you will see 600 patients. So now, interestingly enough, of those 111, 10% had a second genetic mutation. Also, interestingly, if you look at most registries with Fabry disease, it's about 2% African American and about 2 to 3% Hispanic. In this group, it was 12% African American and 12% Hispanic, meaning that we are underdiagnosing in underrepresented populations. All right. So let's talk about another case, avoidance of prolonged immunosuppressive therapies. All right, so you have an 18-year-old who presents with nephrotic syndrome. So his kidney biopsy is consistent with FSGS. Steroids are initiated at a high dose, and he initially responds, but every time you get to about 20 milligrams, the protein just goes straight up. So what do? Well, without further testing, we treat them with more steroids. We'll do it again. Like we'll go back up and try and get it down, or then we'll add tacrolimus or cyclosporin and you name it, and we'll keep going and keep going. And most of it'll be he's young, so we have to protect his kidneys. So what are the genetics of steroid-resistant nephrotic syndrome? So this was work done by Hildebrandt. So single gene causes of steroid-resistant nephrotic syndrome in patients under the age of 25 is 30%. So if I have a steroid-resistant FSGS under the age of 25, 1 in 3 have a genetic cause. Now, interestingly enough, no genetic mutations have ever been found in steroid-sensitive nephrotic syndrome. So one of the questions in the chat from the last one was, should I test all nephrotic syndrome for genetics? And the answer is probably not based on this data. What I tend to do is treat them with steroids. If they respond, great. If they don't respond, that's when I do genetic testing because the likelihood is 1 in 3. Now, here's the real utility of it, is that those with monogenic causes of nephrotic syndrome do not respond to immunosuppressive therapy. So unfortunately, what I have to tell the patient is, well, look, good news and bad news. The good news is that I'm going to stop the steroids because most patients do not like gaining 20, 30 pounds and having moon phases. The bad news is I cannot treat your cause of kidney disease with immunosuppression. I can use ACE inhibitors, ARBs, et cetera, and now we have finerenone, all sorts of stuff, right? But immunosuppressant is not going to work, all right? Now, the good news is that when you get a transplant, or if you progress to the point that you need a transplant, it is unlikely to recur, right? Based on the cause of your FSGS, it will not recur in the transplant. The opposite is true in steroid sensitive. So in steroid sensitive nephrotic syndrome, I get to treat them up front with immunosuppression, but if they progress and end up on transplant, they have a higher risk of recurrence, right? So these are some of the things that I take with me when I'm counseling patients on their genetic tests. So another interesting one, and I'm just waiting to find one. I don't have one yet, but a mutation in CoQ10. So CoQ10 can cause FSGS. The last thing I want to do is put somebody on tacrolimus when I could have treated them with a GNC supplement of CoQ10. So it's CoQ10 deficiency can cause FSGS. So very important population under the age of 25 with steroid-resistant nephrotic syndrome. All right, let's talk about these. So conditions amenable to non-specific renoprotective therapies and conditions at risk of recurrence after transplant. So we have a 45-year-old with ESRD, a cousin with ESRD, aunt with ESRD. Patient has 3 children, and she has FSGS on biopsy. All right. Now, the biopsy in this patient was done actually before we had electron microscopy as a standard. So she is actually much older than this. So they just said FSGS. Oh, sorry. This was wrong patient. Sorry. This patient actually was 45, had ESRD in my dialysis unit and had multiple family members with ESRD, aunt with ESRD, and he had children. All right. So we did genetic testing because I said you have one family member. So it turns out they had homozygous APOL1. Now, what is the implication? Well, first of all, there's implications if you are homozygous for APOL1. Lots of debates going on about donation, right? The next thing is not as intuitive, which is a lot of people say, well, what am I going to do with this? Well, first of all, there's clinical trials, but let's say that doesn't pan out. How many of you on the call between the ages of 20 and 40 go to a primary care doc every single year without fail? I didn't. at all. However, if I was homozygous for APOL1, the last thing I want is diabetes, hypertension to go unnoticed because now I have an extra risk factor. So my counseling to these patients is, yes, you have APOL1, your children may be at risk. If they have this, you need to get them screened every single year. This is not the 20 to 40-year-old you want to say, hey, look, I'll see you when you're 40 for your prostate exam. So, I mean, these are the types of interventions that you can do. Now, it turns out that we keep learning more and more about genetics, right? So, there's this idea on recessive diseases that two copies, right? Two copies you have disease, one copy you don't. And there are diseases like that. But it turns out a lot of them for the kidney, we're going to find out are not like that. And APOL1 is an example. I'll give you another example of NPHS1, ALG8. These are diseases that was historically thought you needed two copies, right? But this is an NEJM paper, and you have an APOL1 talk coming up, where two risk alleles conferred. This was done in a West African population. So two APOL1 risk alleles actually increased your risk of kidney disease by 25%. But the going rate was if you only had one copy, you did not have increased risk. Well, that is not what this study showed. This study showed that compared to G0, G0, which is no risk allele versus one, that you actually had about a 19% increased risk over normal. So same with, I was across the hall from an NPHS1, where NPHS1, you have two copies, you get nephrotic syndrome as a child. But it turns out if you look at those with one copy of NPHS1, they are at increased risk of kidney disease in the future. So as we do more and more of this testing, more and more studies, we're going to find out more and more about kidney disease. And that's part of the fun of this is we get to learn together, but we have to start somewhere. All right. So let's talk about this patient, 69-year-old female, CKD5, undergoes transplantation. She has a past medical history of FSGS. This was the patient who they did not have electron microscopy at the time. Multiple family members with CKD and hearing loss. 3 days post-op, she develops proteinuria up to 13 grams. So I'll never forget it. I get a call from the transplant nephrologist and said, hey, this patient has recurrent proteinuria. Are you sure you know what she has? And I said, absolutely, 100%. She does not have recurrence of FSGS in her kidney because I had done genetic testing. So they did a biopsy, subtotal foot process effacement, C4D was negative, and I said, do not give this person Rituxan and all your plasmapheresis because I knew up front, before she had even gotten the transplant, I'd done genetic testing and she had X-linked Alports. So what happened? They did not do plasmapheresis. They did not do immunosuppression. And now the patient is, over the course of 3 weeks, the proteinuria went away. She is now, probably 8 years post-transplant and doing fantastic, right? Well, creatinine is 1.2. What if we did not have genetic testing, what would we have done? We would have had to assume this was recurrence of FSGS. She would have been slammed with immunosuppression, plasmapheresis, you name it, unnecessarily. And God forbid she would have gotten a complication from one of those therapies. All right. So the other thing that's interesting about this, because people ask, well, what are you going to do about it? Well, now I asked about the family, right? So it turns out the granddaughter was tested. So she told me her granddaughter was doing fine. So I tested the granddaughter for proteinuria. Granddaughter had 5 grams of proteinuria. Now I have to do ACE inhibitor, ARB, et cetera, to reduce the proteinuria. But the other thing, and I have personal experience with this because my son actually has some hearing loss in one of his ears, these patients and their children need hearing screenings because it completely changes the way they interact with the education system. So now, all of a sudden, because I did a test, I can affect the hearing and the education of someone who is not going to see me for kidney disease. So it's important to actually realize that your responsibility when you do genetic testing is not just to the patient, but it's to the entire family, and it's not just to the kidney, is to make sure all of the extrarenal manifestations are being taken care of. So with Alport specifically, I make sure all their children also, at least, they don't have to get genetic testing. That's an ethical issue, but they have to get audiology tested to make sure that they have the best education and best chance possible. All right, there is a phenotypic spectrum of Alport. So there's call 4A4, 4A5, which can cause autosomal recessive or autosomal dominant Alports, and then X-linked, right? The autosomal dominant is probably the one we're missing most because it's milder. Many of those patients can just have a little blood in their urine for the rest of their life, and they have relatively little CKD. So what I think is going to happen is very quickly, I'm going to give it a number. Maybe 80% of our thin basement membrane disease we're going to find has autosomal dominant outports. So just because of how prevalent this is, and we weren't doing genetic testing before. All right. So let's talk about conditions amenable to specific screening for extrarenal manifestations. So the list of this just keeps getting bigger and bigger, right? So one of the things I love about nephrology is I do a kidney biopsy and I see cryoglobulinemia, and now I diagnose their hepatitis C, right, which affects other things. HIV nephropathy, I see collapsing FSGS, I test for HIV, and now all of a sudden I have treated the whole patient, not just the kidney. It is the same with genetics, right? So some of these that are actually probably more common than we know, MODY5. So this is HNF1B. MODY5 causes renal cyst and diabetes syndrome. So they can get misdiagnosed with polycystic kidney disease. The other manifestations, MODY5 is inherited as either single mutations on the HNF1B gene itself, or it can be inherited, about 50% are inherited as a chromosomal deletion called 17q12 syndrome, which includes HNF1B, but also a lot of other genes. So when I have somebody who I identify with MODY5 and your kind of take home, renal cysts and diabetes, yes, but hypomagnesemia. These patients, about 50 to 70%, will get severe hypomagnesemia. So you're going to think they're Gittleman's, but they're not. Most of my hypomagnesemia patients actually are not Gittleman's. They are MODY5 patients. So when you think about it, think about these. But it turns out that MODY5 is a developmental gene, so it doesn't just affect the kidney. So some of these patients will have one kidney that doesn't form at all. Some will have cysts on both, but their pancreas doesn't form, so they'll have pancreatic abnormalities. They'll also have bicoordinate uterus, recurrent abdominal pain, and many of them will get neuropsychiatric disorders like severe anxiety that I've had patients break down and cry when I tell them they have 17q12, and I immediately ask them about their anxiety. And I get to tell them that this was not you. It's not your fault that you have a diagnosis that causes this. And usually the parents cry too, because they thought this was all something different, that it was not genetically related. So other genes, folliculin causes renal cell carcinoma, recurrent pneumothoraces. So you need to do CT scans to look for these cysts in the lungs. They also cause nodules on the skin, which are secondary folliculin. BMPR2, this is kidney disease with recurrent pulmonary hypertension. We've diagnosed one of these who underwent lung transplant because we had diagnosed this in the nephrology clinic, right? Bardet beetle, Alstrom's, hypophosphatemics, you name it, like all of these diseases have extrarenal manifestations, or most of these diseases. And you got to treat the whole patient. If you don't know they have genetics, you won't know about the extrarenal manifestations to address. All right, conditions at risk of recurrence after kidney transplantation. So you have a patient who presents for kidney transplant, ESRD of unknown etiology, but has had a history of multiple kidney stones, right? So, urology takes out the stone, and then patient goes home, then urology comes back, takes out the stone. They have chronic bone pain, right? Now, so a living-related kidney transplant is performed. 2 weeks later, the patient has delayed graft function. They do a kidney biopsy, and unfortunately, it shows oxalate crystals throughout their kidney. All right. So what is that disease? So it turns out we did genetics, and the patient had a mutation in AGT. Patient had primary hyperoxaluria, right? So we're getting to a point now that you have KDIGO, you have NKF, you have NEJM for reasons to do genetic testing. We just put a kidney and lost it in a patient that we could have saved the kidney, right? If we had done a liver kidney transplant, because the liver transplant fixes the defect in AGT, so they actually metabolize the oxalates appropriately and would not have deposited in the kidney itself. The other thing is you have to manage these patients differently around the time of transplant. You need to aggressively dialyze them to get the oxalate level down as low as possible before you put the kidney in, so you do not have this delayed graft function. All right, so liver transplant, and now there are some siRNA targeted therapies for primary hyperoxaluria. All right, case 7, patient found to have chronic kidney disease by PCP and undergoes a renal ultrasound. The renal ultrasound shows multiple cysts, and the patient says, I want genetic testing. All right. So now we'd all think this is PKD1, but it turns out not the case. So patient had a heterozygous mutation for ALG8. Now, ALG8 is another one of these diseases that if you have two copies, it causes a completely different disease. It's a disorder of N-glycosylation. So patient will have seizures, they'll have developmental delay. But if you're a heterozygote for ALG8, these patients can actually present just like polycystic kidney disease. Now, the interesting thing is, well, do you manage these patients differently? And the answer is, I don't know. We need more data. So, for instance, one of the questions is, should I screen this patient for cerebral aneurysms? I don't know. I know the data in PKD1, and I know that likely the data in PKD1 was mixed with some ALG8 patients, but the reality is we don't know. So we need to know this. And there are other genes. So these are all the genes that are available. There was a question in the chat, do I test all my PKD1 patients for with genetics? And the answer is most of them. Now, will I test a child, right? So if I have a PKD1 patient that I did genetics on and I know the mutation and the child comes in with multiple cysts, you probably don't need to test that patient. You know what they have because you have the family history. But if the family has never had genetic testing, right, then you probably, at least one of them needs genetic testing because these cause cysts in the kidney without causing PKD. One of the ones you should actually, draw your eyes to is Alports can cause cysts in the kidney. So just because it has cysts does not mean that it is not Alports, right? So you need to do genetic testing on at least one of these patients. All right. So the other opportunities that we're going to talk about is just adding to the existing knowledge of kidney disease. So we don't know what we don't know. And I'll just give you an example in Fabry disease, right? So what happens is, and you're going to get a talk on the interpretation, right? So the interpretation of these tests has pathogenic, likely pathogenic, non-pathogenic or benign, and then a VUS. So a VUS is called a variant of unknown significance, right? Well, that doesn't mean it's not significant. It means that is up to us to put the significance on it, right? And, the story that's like MGUS, right? Monoclonal gammopathy of undetermined significance does not mean that it isn't monoclonal gammopathy of renal significance. What is the difference? The kidney biopsy. So in the first patient that we identified who had the Fabry disease, that actually came back as a VUS, right? But the enzyme activity is 0. The patient's the lysogl3 is up. The patient's clinical and his family all have the symptoms. This now I can submit to actually change the classification of the VUS to pathogenic. What does that mean? That means not only have I helped this patient, I have helped every other patient from here till kingdom come that gets a genetic test with this mutation because it will be classified as pathogenic. If we don't add this, we need to be lockstep with the geneticists so that we actually provide real clinical information so we can appropriately change the VUS. In order to do that, we have to test and we have to find, we have to go one step further to say, yes, this is a VUS, but should it be reclassified, yes or no? All right. I liken genetics actually kind of, before everything used to be Bright's disease, right? So, when we only had light microscopy, we had Bright's disease. And then what happened is we added immunofluorescence to light microscopy. And then we added electron microscopy to immunofluorescence. And Bright's disease became 100 diseases, right? Genetics is going to do that for many diseases. FSGS, PKD, all of those are one of them that we had one phenotype that is now expanding as we know more and more about the pathogenesis. So this is my, before KDIGO had their guidelines, this is how I kind of approach things. So, who needs testing? CKD less than 25, most of those patients should probably get genetic testing. First degree relative with kidney disease, but that means you have to ask and you have to pay attention and you have to say, I need to do genetic testing. CKD plus syndrome. So, these are the all of the diagnoses that you never want to hear, like hypothyroidism, but their thyroid disease is normal, fibromyalgia, irritable bowel syndrome. So when I see this conglomeration of diagnoses that are syndromic but not specific, I used to say, man, this patient complains. But now I think we just haven't done the right test, because it turns out that the usual way that things go, and I know this just because my patients don't get diagnosed until I usually see them at the age of 30, right? And this disease, Fabry disease specifically, starts in many of these patients at the age of 5. So what happens is the patient complains, the doc sends a test. The test comes back normal. Then the patient complains, the doc sends a test. And so eventually the doc gets fed up and said, all your tests are normal. This is in your head. You have somatoform disorder, right? I mean, they label the patient, because if I can't diagnose it, it's the patient's fault, right? Usually it's just that we haven't done the right testing, right? That's when we need to take the next step and do the genetic testing, right? So if you think they have one of these, or the KDIGO or the NEJM reasons for testing, then you do gene panels. Gene panels are inexpensive. They give you a wide swath of genetic disease, right? That's probably the first step. Now, if the gene panel is positive and you want to treat it because you understand it and you're going to go the extra mile, then treat it, handle it yourself. If the gene panel is positive and you're uncomfortable, or you think that a referral center would be better to treat it, like a center of excellence for that disease, then send them, right? But all general nephrologists will need to be able to send the panel. You got to do the test and then figure out what to do after. Now, here's the really tricky part, though. What if it's negative, right? So it turns out if it's negative, you're not done. Because then you have to ask yourself, well, how likely was this to be a genetic disease? And if the answer is it was really probable, and the patient had multiple family members, I still think this is genetic. That's when you need whole exome or whole genome, right? Now, in most of our clinics, most general nephrologists will not have access or want to have access to whole exome or whole genome. And the reason is it gives you a lot of data that you're probably not going to want to talk to the patient about, right? I mean, I'm not good at talking about BRCA risks and things like that. So if you want, most people would actually refer these patients to genetics. That's when you would refer to genetics if you are not a genetic nephrologist or nephrogeneticist. However, if you say, look, I sent it, but I wasn't really that positive that it was, then you need to do standard of care. You do need to know there are some misses, like Dr. Narusi talked about. Probably one of the biggest misses is MUSE1. So that is ADTKD type 1. It's a copy number variant that she talked about. Your history for that is I have a chronically increasing creatinine, but no protein, no blood. It is a bland urine sediment, right? That disease is missed. And a lot of times biopsy will show FSGS, right? But that disease is missed by gene panels. So if you're worried about that, multiple family members, this is also when you say, I need to do other testing. But my portion of this is the gene panel. If if that comes back negative, but I'm still worried, I'm going to send it to somebody, center of excellence, geneticist, et cetera, that will know some of these big misses that we need to account for. All right. So the conclusions, genetic testing, it's easily available. It's affordable for most of my patients. I'm in Alabama. This is an underserved patient population. Definitely don't have a lot of dollars, but all of my patients have been able to actually do this when counsel said this is an important part of your care. We save money, that we save the system money from avoiding a diagnostic odyssey. So, a lot of times we just keep sending tests and wasting dollars, but we're not sending the right test. We need to identify the systemic diseases, and in some cases, systemic diseases that need therapy. We need to identify the family. Like I said, it's one of my favorite things. My dad was an internal medicine or primary care doc, and I always loved that he took care of families. And now when I do genetics, I have some families I take care of 4 generations, and it's very, very rewarding when you become part of the family because you have diagnosed their genetic disease. So prognostic information for transplant, add to the existing knowledge of kidney disease. And actually, at some point, and I think we're not very far from this, at some point it may be a liability not to test. The first person that actually gets, we're just waiting for the person who gets a kidney and not a liver that could have been avoided because we actually did the genetic testing. I think that's probably where things are going in the future. So with that, I will take any questions.
Thank you so much, Dr. Wallace. That was great and very insightful examples as well. There were several questions in the chat. Maybe perhaps I'm going to bring them up, and then I had a couple of questions as well. So the first one is, and that's also interesting because now with pre-implantation diagnostics and so on comes in, is what is the recommendation for avoiding transmission of disease, genetic diseases, I would say, to offspring?
Oh man, that's a loaded gun, right? So the thing is that that's a very personal question that I don't usually get into. But here's the reason, right? So it's not ever cut and dry. So take a Fabry patient. You take a Fabry patient, a Fabry male, right? Now they have a female, but Fabry females don't get a lot of them. The likelihood is they're not going to actually get a very big phenotype. And it turns out some of the nicest people that I know are Fabry patients. So do we want to eliminate Fabry, knowing that you say, yes, you might transmit the disease, but it's part of the disease that makes you who you are, right? So that's different than things like trisomy 18, for example, where but even then, this is so it is very personal. So I tell them the options, right? But I, for one, am not the one recommending, hey, you need to do in vitro because of transmission of disease. Now, there's another interesting thing, and this gets into the weeds, which is just evolution, right? You know, Evolution itself, a lot of times when we think it's bad, we're wrong, right? APOL1 actually conferred a benefit to people with trypanosomiasis, right, in West Africa, right? So if we as humans decide we're going to pick the genes we don't want, we're opening ourselves up for not having genetic diversity, which is specifically why our species exists. So, I think, that's why it becomes very, very complex very quickly. So my job in that is not to say what I would do, it's to provide them options and then let the patient decide because I think that is far more personal than medical.
Thank you very much. Um, Genetic testing ultimately depends on the science, and science is evolving for us to understand and identify new mutations and put these new mutation into the database so that when we test, it's connected with an underlying pathology. Now, sometimes we have a pathology of a patient where we say, this patient is young, has FSGS, it's steroid not responsive, it's not primary FSGS, must be genetic. We get genetic testing and it comes back negative, or it comes back with a bunch of variant of unknown significance. What is your approach in repeating the testing
So
again and
no,
as
that that
things?
that's a great question. So, and a lot of people, so first, people should know that the American College of Medical Genetics, the ACMG, says you should not use VUS to actually count or to treat the patient, right? So what you should use is pathogenic, likely pathogenic. You should use that unless you have supporting evidence like kidney biopsies, or et cetera, right? If a VUS, though, you should also know. So in most places, you can elect to know about the VUS or not. So some people elect not to even get the VUS. So the report says negative. I don't recommend that. I always get the VUSs. Now, what I can tell the patient, though, is that this one might explain your disease. We don't know it explains your disease. However, we are learning. And so if there is enough evidence over time to change the classifications, the genetic testing company actually has to go back through their database and contact patients who have that gene. So we should be notified if the VUS classification changes, right? So this isn't a one and done, which is part of the expense of genetic testing, is these companies have to go back. Now, that withstanding, a lot of my genetics colleagues say, look, things are changing so quickly that if a patient wanted, they would wait 5 years. And so a lot of my genetics colleagues would say, look, we didn't know as much as we know now. So if it's been 5 years, you might want to retest if you haven't heard something. But in that case, if I'm doing retesting, I'm probably doing whole exome. I'm probably not going to retest somebody just with a gene panel. I'd probably do a whole exome. But it's a great question, and one that, like I said, it's going to take all of us to add to this database and build it because we just keep learning.
Thank you. There is a question by Dr. Tandra that can we refer patients to general geneticist or a center of excellence if we have variant of unknown significance? It's often very difficult to get them referred from community.
Yeah, the answer is yes, you can. A lot of them, but here's the problem, right? There's not enough geneticists. So genetics is exploding. Unfortunately, if you look at the interest in genetics as a specialty, let's just look at all specialties, right? Nephrology, then it goes geriatrics, and then it goes genetics as far as some of the least interested. Now, nephrology is on the uptick, and I think it's on the uptick because of how exciting some of this stuff is. But bottom line is there are not going to be enough geneticists. So, expect a wait of a year in Alabama to get into genetics. So what this tells me is that each specialty is going to have to own its own genetics, and then we're going to have to refer up when we need it, right? So the VUS is going to be an interesting one because if I've already done genetic testing and it's negative or it says VUS, then what the geneticist says is going to say, well, you've already done that, right? You've already done the testing. We'll wait the American College of Medical Genetics. You'll get some sort of canned answer, right? So the real question is not necessarily for the VUS, it's when you think you need extra testing, right? So if you refer up, you say, I do my general panel, I still think it's genetic. Now I'm going to send to genetics, but probably not for an interpretation of the US. Now, there's another thing you could do because now these nephrogenetics clinics, and full disclosure, I am not a geneticist, right? I was just experiential learning, reading, et cetera. I am a nephrologist. I do not have genetics training. But what's happening is people are realizing that they can't get into genetics. So nephrologists themselves are taking over. And I would probably refer to a nephrogenetics clinic to put VUS on a kidney disease because we know more about the kidney. And if this is related, then actually a geneticist. The geneticists know more about the testing, but we know more about the clinical manifestations.
Thank you. One last question, and then perhaps we can do a 5-minute break before moving on to the next one is a patient comes and says, my kid, I have proteinuria. Let's say it could be Alport, an Alport patient of yours, or it could be a PKD patient of yours comes says, my kid is 16 years old, has no proteinuria, has nothing on ultrasound on cyst or anything. Uh, can you do a genetic testing on him?
Yeah,
What do you tell the patient?
this is where it gets much, much harder, right? So the asymptomatic family member of a patient with kidney disease is a little bit harder. And for some of it, it depends on the disease. Like for instance, Fabry disease, I have a treatment. I don't want to not do genetic testing when my pre diagnosis is something that would get treatment. You have to treat them first, but you do need to counsel, right? So the counseling that you'll give is something called GINA, which is the Genetics Information Non-Discrimination Act, which basically says, look, for a kid, I can't discriminate against you for health insurance using genetic information, but I can discriminate against you with genetics for life insurance, right? So that's the issue. So usually I counsel the family if they want life insurance, it's inexpensive to get a life insurance policy on a child before they get tested. So you might want to do that, right? So that's one part of counseling. The other thing is It could be one that I don't do genetics. I don't do genetic testing. What I do is I have them screened, right? So for instance, in things like Alport's disease, where I don't necessarily want to diagnose an asymptomatic individual, but what I do want them to do is do urine screenings. And if they get protein, blood, period, all bets are off, I do genetics. So depending on the pre-diagnosis is how I counsel those patients. But the asymptomatic family member is more difficult. The one last thing I'll say, which it comes into the referral, which I meant to say. So I got into telehealth. So I'm the chief medical information officer of my health system, but it's because I got into telehealth and I got into telehealth because of genetic kidney disease, because all my patients were driving hours to see me. So now, if we can actually get, so I have licenses in 5 states to do telehealth only for genetics. This is the power of technology. So as soon as we add this giant database, genetic testing, my whole thought was that nobody should not be able to see a specialist in their disease. So telehealth has the way to do those referrals. So if you say I can't get the help I need, I can't refer to a specialist, then what I would do is I'd find a specialist that does telehealth into my state so that if I, as the general nephrologist, and I'm comfortable, I refer to a center that does telehealth so my patient can get the care they need. Because in many cases, you don't need the patient to get that knowledge of someone who has experience with that gene.
Excellent. Thank you so much, Dr. Wallace, again for your insight, sharing those cases and the overall algorithm. There was also a question with regard to your algorithm, whether it's citable and whether we can cite it as Dr. Wallace
I,
algorithm.
I,
Like,
I have not published my algorithm as of yet, but
okay.
feel free. I think you guys do they get access to the slides?
Yes, not the slides, but the recording, and we will put it up. Yes.
Okay. Well, from
Great.
my standpoint, that is public knowledge. It is not copyrightable, and I think it'll probably change. But yes, please, you could cite this presentation, but it's not published anywhere.